This is our last session of the Antimicrobial Stewardship Program for this cohort, and we'll talk at the end about whether or not you all feel that you need any continuation of that. We're going to turn this over to Angela and her group at Castleview Hospital. And Angela, before you give us your case, can you tell us a little bit about Castleview Hospital?
What about Castleview? Okay, I'm going to let our Leslie, because since I don't know a lot, so I'm learning too. So I'll let her tell about Castleview Hospital.
What do you need to know? We're actually a 39-bed hospital. We're licensed for 39 beds. We do have some freestanding clinics. We have a wellness center. We have an urgent care. We have a surgical center. We have a clinic in Emery County. So we have lots of things going on. We are an acute care hospital. We are actually in Price, Utah, which is about an hour away from Payson. And we're on everybody's way to Moab and Canyonlands and all of that. So we do see some trauma. We do a fair amount of orthopedics. We have recently seen an increase in our inpatients. For this time of year, we're really seeing a lot of we're seeing pneumonia and things that we don't even see a lot of this time of year. So it's, we've had a bunch of different things. We do a fair amount of surgery. We do a lot of outpatient surgery. We do maternity. We do labor and delivery. We have a 6-bed ICU. ER can be fairly busy, especially this time of year with everything in the summertime. We just do, because of our location, we just do a little bit of everything, to be honest. Can I answer anything about us? Or we just recently went through a new renovation, so we do have a brand new ICU and ER that we're very proud of.
And pharmacy.
And pharmacy, we do beautiful pharmacy. We actually have a great pharmacy department. That's about all I can think of.
It's a busy place, it sounds like.
Anybody
have any questions for Leslie before we go on to the case?
Hey, Leslie, this is Eddie Stenium. What kind of physicians do you have that are working there? Mostly family practice, any internal medicine?
We have both. We have family practice, internal medicine. We have surgeons. We have an ENT. We have a urologist. We have a hospitalist. We have 2 hospitalists. Orthopedists. We have 2 orthopedists, 2 surgeons, 3 OB docs. So a little bit of everything there too.
Great, thanks.
Okay. So do you want to turn it over to your pharmacist to talk about the case?
Absolutely.
Go ahead.
Okay, I'm Danita, I'm the pharmacist, and I don't necessarily have a case per se, other than just things that kind of come up that we thought that maybe we could get some clarification on. And my first question is, for your experts, is what are their opinions on starting broad spectrum antibiotics on, say, for example, a nursing home female patient with no UTI symptoms that comes in with a positive UA and negative cultures?
Happy to talk through that. Anybody want to take a stab or give us some thoughts on what other hospitals are doing for those kind of patients?
Jessica, you want to? Okay, we've got from Doug, if no symptoms, we don't treat.
That's what we do over here. If no symptoms, we may or may not get a culture, but we are, at this time, we're observing, making sure that there isn't something hidden that we're missing, but we don't automatically jump on the antibiotic bandwagon.
That's awesome. That's awesome. Those are great points that I hoped you guys would address. So Leslie, nursing home patient, they're going to have many times a positive UA, and many times they'll have a positive culture, and that's just asymptomatic bacteria. We know if we treat those with antibiotics, whether IV or oral, we cause more harm than good by causing more symptomatic urinary tract infections in the future, and then also more resistant organisms. And so in the case you presented, a nursing home patient that comes in that has a positive UA, no urinary symptoms, regardless of what the cultures grow, doesn't have to be negative. They can be positive for this, for all that we care. No treatment. Are you referring to somebody coming in with septic shock, or just somebody coming into a clinic who's got a positive UA that's a nursing home patient?
You know, commonly the patients that we see are coming in with altered mental status, and so they're not completely asymptomatic.
Yep.
But we have a couple of doctors that are jumping straight to meropenem every time.
Yep.
And so we're just wondering what the recommendations are that way.
Yep. So the new IDSA guidelines on asymptomatic bacteria address that particular patient in and itself. If those patients are clinically stable, meaning they're not in septic shock, they are stable going to the floor, and they have altered mental status, the recommendation is you treat them conservatively. You give them hydration. You look for other causes of altered mental status, whether it be acute kidney injury or any other kind of etiology, and you do not give antibiotics. So even in altered mental status, if they're clinically stable and they have no history of symptoms of urinary tract infection, we do not treat. You need to contrast, though, that with a patient that comes in from a nursing home and is maybe going to one of your new 6-bed ICU kind of rooms that are requiring IV vasopressors, they're febrile, they've got a white count of 40. That's a very different conversation, right? Those patients have septic shock, and
that's a different, yeah.
Yeah, but patients that are altered that don't have any prior symptomatic urinary tract complaints, I definitely would not give meropenem. I would just treat them conservatively and see how they do.
Would there be any time when you would treat with a more conservative antibiotic, or do you just not treat at all?
We just don't treat. I mean, we recommend not to treat. I see this every day, even here at Intermountain Medical Center, where people get admitted through the ED on antibiotics for altered mental status just because they have positive UA. So don't think that we're above the fray on this. Our recommendation: altered mental status, elderly coming from a nursing home, no localizing signs or symptoms, withhold antibiotics. If they are coming in and the best you can do is to get your clinician not to give meropenem, then use something like cefazolin or ceftriaxone, something that targets E. coli. If you're going to meropenem from the get-go, your docs are using the broadest spectrum antibiotic that we have that we can give safely and cheaply. So that definitely should be something that we try to avoid.
All
Does that
right,
make sense?
We'll pull those IDSA guidelines and send them to you.
Mm-hmm.
So
that would be great, because that I could present maybe to the docs and have some evidence. That would be nice.
Yeah, it's a relatively new guideline, and they specifically address the patient with altered mental status. So it'd be worth taking a look at and kind of circulating that. It's a hard practice to break, giving antibiotics for somebody who's altered that has a positive UA. But I definitely wouldn't give meropenem. And I'm assuming they're thinking, oh, they're high risk for drug resistance. I would just not treat them.
Okay. And then my other question deals with patients who are on, so we have a lot of patients that we treat for Crohn's, ulcerative colitis, and other kind of immune issues. And they come in with whatever infection it may be. Pneumonia is primarily, I think, is what we see. Mm-hmm. Do we treat them very much differently as far as antibiotic use?
No, there isn't. I'll be interested to hear what other people have seen. We really don't have any kind of guidelines for the treatment of pneumonia in somebody who's immunocompromised. So particularly in the conditions you addressed, so Crohn's, ulcerative colitis, I would kind of put that into patients on immunomodulatory agents. So that would be extended then to like rheumatoid arthritis, psoriatic arthritis, things that are on these biologic agents. Unless they have a history of drug resistance, unless they've got recent hospitalizations, unless they have prior antibiotic therapy, unless they have something else pushing them to a drug resistant kind of profile, just that in itself does not warrant then any change in antibiotic therapy from the standard management of community-acquired pneumonia. Those people can get strep pneumo just as well as the non-immunocompromised patient. So in those patients, we still use, so for pneumonia, we use something called the DRIP score. That's the drug resistance in pneumonia score. And that is what replaced what we used to call HCAP, or healthcare associated pneumonia. We still use just a score like that to tell us whether or not we're going to use broader spectrum antibiotic therapy. So for community-acquired pneumonia, I would still go with azithromycin and ceftriaxone in those patients. What do other people see?
So just because sorry.
Sorry.
I was just going to ask, just because somebody's on those kind of medications with biologics doesn't mean they need a broader spectrum antibiotic.
Nope, absolutely not.
Perfect. Okay, thank you.
Nope.
Well, and does everybody have that DRIP score? Because I have to admit, that's the first time I've heard of that.
We can send you the link to the paper. It's also on MedCalc in terms of how you calculate it. It's the way that we assess patients that have risk factors for drug resistance. I'll put the link in the comment box right now.
Okay.
The nice thing about the DRIP score is that it was developed here. It was developed by Brandon Webb and myself and Nat Dean within Intermountain, and then has been validated in other facilities as well. So it's one of the national measures now that people are using to evaluate patients for drug resistance.
Well, and Elaine, maybe if you could copy that too, we'll send it out also by email in case people don't get it from the chat box, because we do have some comments that they do not have it.
Mm-hmm.
Okay.
Anything else you have for us, Tamina? And did I pronounce your name correctly?
You did get it right. Do you have other questions?
Any advice on the best way to communicate with our doctors to get them to understand some of these ideas?
Yeah, I'll reflect that to the group to hear what other people have done before I opine on that.
Your peers probably have the best information here.
Yep.
Anybody want to speak up?
So this is Kara, and what we do on that is we actually have a program that kind of indirectly addresses that, where we review all of our cultures and we match them to our antibiogram. And then if it doesn't match up on our antibiogram, then we send the provider a letter with a copy of the antibiogram explaining that this the antibiogram is just a tool, so it doesn't mean that it's was not appropriate, but that it wasn't indicated on the antibiogram or whatnot, and it gives our pharmacist number that they can call for questions or education. So that's kind of how we get at that indirectly.
What do you mean by it doesn't match to the antibiogram?
So we have our antibiogram, and then we review all of our positive cultures for our facility, and then we look at the treatment, what the physician prescribed, and compare it to the antibiogram and make sure that it was an appropriate match for our antibiogram for that bug drug. And then if it doesn't match, then we send a letter to the physician prescribed. Say if like the sensitivity of that particular bug was like 70% or whatnot for the drug they prescribed. then that's what we'll send a letter or whatnot to the provider. And then we have provider meetings where they kind of get together in various, like our surgery committee and medicine committee, and then we have our clinic providers get together for a meeting once a month, and we've gone and done various education and updates on the updated IDSA guidelines and whatnot. So that's how we've kind of tackled that issue of communication with the providers.
Have you got good feedback from it?
We actually have. I was surprised that people actually read the letters. So we got feedback from several of our physicians, either saying thank you, or they have questions, or they want to justify why they use that drug. For example, maybe the patient was really renal impaired or had multiple allergies to other drugs, in which case that would be, and there are instances where the pharmacist said, yeah, I would agree that was the best option at that time. So just kind of a way to make sure the providers know about the antibiogram tool that they have in their toolbox.
Yeah. What are other people doing to communicate with docs or advanced practice providers? Or
Here at Boulder City, I found that it's easier just to take all of the pieces of paper with me and discuss it one-on-one with the providers, and just listen to them. And then usually they'll either say, yes, I'm going to do this, or, oh, I didn't even think of that. So here I use a one-on-one. Stephanie, our pharmacist, does the same thing. We kind of, not together, but individually tag team them.
Right. So that would fall under what's called handshake stewardship. This is something that's getting a lot of traction nationally. And so it's really meeting the providers face to face and engaging them face to face where they're at, whether it be in the clinic or on the floors. And what that does is it obviously increases engagement. You know, if you are willing to come meet them and give them recommendations face to face, then, you know, they see you as being an active part of the team. And that's had a lot of success, and it's a great way to communicate with them, as long as you can consistently find them. And it's just a matter of kind of understanding what their rounding schedule looks like and meeting them at a time which is convenient. We found that that's been very impactful. Have you guys found that it's been received well? Very received well.
Yeah. Especially recently, we've gotten a few new doctors in that I haven't met before. And so I'll either stay late or come early in the morning and introduce myself and tell them I do have a concern. Can we talk about this?
Yep.
A donut and a cup of coffee always works well too.
It sure does. It sure does. You know, one of the things that we've done that pairs well with exactly what Jessica's talking about is if you have institutional specific guidelines and they're treating a patient, let's say with community-acquired pneumonia, and they're using let's say Levaquin, and your local guidelines recommend Zithro and ceftriaxone, that's a great time to educate to your guidelines and to say, hey, do you know where you can find these? Or, hey, there's an order set that has these embedded. And so you can really tie your education into your local guidelines and assess compliance with your guidelines all at the same time. And you can do that face to face. And so that's a great time to really bring up and highlight those common conditions. So pneumonia, urinary tract infections, and skin infections. If you can develop guidelines for those, and then you can bring them to your face-to-face rounds, I think that helps.
Well, it looks like Jonah said that that's what they do there too.
The downside to that is it's time intensive, and you have to obviously be prepared and come to meet the docs. And in larger facilities, we don't do handshake stewardship for everybody in the hospital. We would never leave the hospital if that were the case, but we do select teams on a day-to-day basis. Yeah. Leslie, did that give you some ideas?
Yes. Yes, thank you very much.
Yeah. You know, just summarizing, I think meeting the physicians where they're at. So going to their meetings and their provider meetings, and having a very, well put together short presentation on what you want to talk about. I think it's a great way. And then, engaging them on a consistent basis, whether it be daily, every other day, weekly, with some kind of form of handshake stewardship, where you're actually engaging them, giving real-time recommendations on patients that are in the hospital, I think goes a long way.
Are there any articles on that we might be able to send out to the group or not?
Not
I've heard that, but I've not seen anything in writing.
in terms of what, Sarah?
Like an article on how that works, how well it works?
The article that kind of coined the term handshake stewardship is, it's out. It's by a woman named Sarah Parker from the University of Colorado. The first author was a woman named Hurst, H-U-R-S-T. And it was in the pediatric population. But that being said, it's being used in across the U.S. But I'll put the link in the comments.
Okay, thank you. Other questions for Damina and Angela and Leslie? Any other offers of support? Okay, thank you so much for taking the time to present to us and listening to the feedback of the group. Was it helpful to you?
Yeah, definitely.
Okay. All right, sorry, go ahead. Okay. Okay, so we're going to go on. Next slide, please, Mike. So we're going to talk a little bit about comprehensive unit-based safety programs. And the reason I want to pull that in is because one of the elements that we talk about at Comagine is quality improvement. We've spent all of our time in this group on the actual nuts and bolts of antimicrobial stewardship. But one of the things that can facilitate your program is actually having a safety program that fits well and meshes with antimicrobial stewardship. And, I'm going to ask Dr. Stenium to comment. This is actually my presentation, so, but I would welcome anybody's comments as we go through this. Next slide. So there's something out there in the literature now called high reliability organizations. And what they're looking at there are organizations that consistently have outcomes that are better than some of the other hospitals in the same category. So they're not comparing rural hospitals to universities. They're comparing universities to universities. Bottom line, these are the 4 elements that they say should exist in any organization that's really highly reliable. That there's an acknowledgement of how high risk what we do in hospitals is, and a determination on the part of the providers to make sure that there's a consistently safe operation. That there's a blame-free environment, and before you all get worried about that, those of you who are administrators, I'm not talking, when I usually talk about this, I go through the whole training of, there's such a thing as accountability. So we're not talking about the person who is consistently sloppy in their work or makes errors consistently and, purposely does harm. We're talking about blame-free environment for mistakes. And I would bet every one of you recognize that probably 80% of all adverse events that happen to patients fall into that category. Nobody did it on purpose. Probably more like 90. This is not something that people go out there trying to do. Yes, there can be behaviors that really do facilitate that outcome. I always like to use the car, in an accident. Somebody who's driving, they just somehow miss the stop sign, they hit somebody. That's entirely different than the person who just had 6 beers, misses the stop sign and hits somebody. It's an accountability issue because they knew that that was a risky behavior and they did it anyway. There's collaboration across the ranks. All the disciplines try to seek solutions and they try to solve patient safety problems. And then there's a commitment of resources to address safety concerns. And I know all of you are small, so you can't commit the same level of resources that Intermountain can. But within your realm, you can commit the resources you have. Next slide. So, Institute of Medicine says that there should be 3 things. There's an emphasis on preventing errors, learning from the errors that happen, and building a culture of safety that involves all of your healthcare professionals. And kind of, Demina, this goes back to your question of how do you get the docs to listen? This is what you have to have in order to be effective. Next slide. So CUSP is called the Comprehensive Unit-Based Safety Program. It was a model that was promoted by the Agency for Healthcare Research and Quality, AHRQ, and it was actually promoted a long time ago. Some of it's time intensive, but there are elements and tools that you can use to help you in your antimicrobial stewardship program. Next slide. So how do you fit it in? Here are some of the principles, and I think you're going to recognize them. Standardize. One of the things we've talked about in this program is having guidelines for things like UTI, pneumonia, skin infections. Standardize your processes. Create independent checks. So, you know, it's not just the doc who's worrying about this, but the infection preventionist is involved, your lab is involved, your nursing staff is involved in the process. And learn from the defects. Learn from the things that don't work, how to fix it. Basic component is strong communication process. And we're going to send you all these websites, but I will tell you, this is really good to look at because it talks about how communication works. And it's very enlightening that it's not just about words. It's really about how we say it. Both are a team-driven process. CUSP requires a team, so does antimicrobial stewardship. And they're both very focused on patient safety and satisfaction. And before you say satisfaction is not an element of antimicrobial stewardship, I would bet that some of us would argue it is. Those of us who have been risk managers or infection preventionists and have gotten the complaints, and I see Jessica's head shaking. I mean, this is just the reality. It's an element of patient satisfaction. Next slide. So it has a foundation in teams. All team members are empowered to speak up. You have to, for your antimicrobial stewardship program, have nurses who are willing to talk with your physician. Just like Demina said today, you also have to have infection preventionists, quality directors who are willing to talk with that physician when things aren't going well, and they're empowered to speak up. And I always like to talk about, you've probably heard that in a cockpit of an airplane, there's a level playing field. Now, I don't know in healthcare if we're ever going to get to the point that we have a level playing field. But a lot of accidents were actually caused in the 70s, 80s, and 90s by the fact that the captain was considered the final word, and nobody would go up against him or her. And accidents actually happened because the co-pilot knew something was wrong, but he wasn't comfortable saying it. He was just hinting at it. And you hear it on these cockpit voice recorders. It's the same thing in healthcare. We have to empower our staff to be willing to speak up when there's an issue. The decisions are based on accountability and responsibility, And the communication channels are well defined and there's open communication. Next slide. So there are some tools within this model. One of them is called Team Steps. Anybody ever heard of Team Steps? Okay, so this is a model for leadership. This is designing your leadership model around your program. You can use it for your program for antimicrobial stewardship. This is actually meant to be a management model for organizations. And it's very, very focused on ensuring that performance is based on knowledge and attitudes and those 4 elements that are in the center for the patient care team. Next slide. And it's also based on just culture. And I love just culture because just culture defines the difference between an error that's caused by distraction, like that person who runs through the stoplight accidentally, and errors that are caused by behaviors that are at risk. And that last category is where just culture says there needs to be not just a root cause analysis, but something addressed with that person. So it kind of gives you a model for addressing problems that occur within your organization. Is there a difference between the physician who used meropenem once and then you talk to him and he changed his practice, or the physician who says, I don't care what you say, I'm going to use meropenem whenever I want to. There's a difference there, isn't there? So that's the just culture model. And it's really just a framework for establishing a culture where accountability is balanced by responsibility. Next slide. So there are some tools in this system that you could use in your antimicrobial stewardship program. Observing patient care rounds is very focused on safety issues. You could refocus it for your antimicrobial stewardship program, observing whether or not there's an issue going on with the patient, did the staff member address it, and did the physician respond, and how did they respond? Shadowing another professional is actually watching somebody who's very familiar with this process and learning from them how you actually implement CUSP. And then the team checkup tool is actually an assessment of where you are as far as your safety program. How do your staff feel? How safe are they in their organization in addressing concerns? And then that morning briefing, that's your huddle. That's where you get together and say, this patient's on this antibiotic, the cultures just came back, probably needs to be changed, hadn't been able to get a hold of Dr. So-and-so, that needs to be followed up. So you can see that you can actually use these tools within your antimicrobial stewardship program. Next slide. So OSHA says that the benefits of implementing safety and health management systems not only help your patients, they save money, they protect your workers, and making an all-hazard specific program is more specific and effective than just focusing on one element. So CUSP is designed to do it to work with all of those potentially harmful situations. But in this case, we're talking about using it with antimicrobial stewardship. Okay, next slide. My favorite saying, the largest room in the world is the room for improvement. You're not going to get there tomorrow. This is something that takes time to get an antimicrobial stewardship program in place. If you choose to use CUSP, it takes time to get it in place. And I guess what I'd like to say to you from the Co-Imagine Health HIIN group is that we are here to help you. If you need anything, if you need something from Dr. Stanyam or from Dr. Spivak, let us know. We'll follow up on that. This is actually our last session of this series.